Getting the weight.
All right. Good morning for Brazil and good afternoon for India and other countries. And it's a pleasure to have POOJA KANDULA talk about fluorescence and geography. And you know, this is a very important and great subject. We always have to deal with that in the daily basis, in the daily clinic. And still people don't rely much on FFA on those days because we have so many exams, you know, such as OCT, all they complement each other. Everything complements. So I think it's something that the doctor has to take with him into the OR, into the laser room, to the knowledge and elsewhere. And thank you, Natarajan, for making that possible. We are always happy that we have more residents and fellows from our part here too. And we are broadcasting live through a Reconnaissance channel. And also we are recording these for future studies from whoever is interested in this field. Thank you very much. So could you pronounce your name again? POOJA KANDULA? I don't know if I...
Yeah, my name is POOJA, sir.
Okay.
Thank you, and thank you, Natarajan, and especially Aishwarya, for giving me an opportunity to share my knowledge on fundus fluorescein angiography. I would especially thank Dr. Gopal, sir, for always encouraging me to present on various platforms. Moving on, fundus fluorescein angiography. These are usually very essential to accurately evaluate, diagnose, and treat patients with retinal vascular and macular diseases. I will be covering this topic under the following headings: basic anatomy, principle, technique behind fundus fluorescein angiography, interpretation, and abnormal patterns that we see in a fundus fluorescein angiography. Why do you have to know the anatomy is because that is how we will know the various abnormalities that occur. Retinal and choroidal vasculature are very important. In retinal, we have dual circulation the choroidal vasculature, we have parallel which are non-fenestrated and do not allow the dye to leak. So when there is fundus fluorescein angiography, usually permits the dynamic evaluation of the local circulatory disturbance, and this helps us to identify the blood retinal barrier breakdown. We have two blood retinal barriers, that is the inner blood retinal barrier and the outer blood retinal barrier. Outer blood retinal barrier, as we can see in this picture, is formed by the RPE cells along with zona occludens. And inner blood retinal barrier is formed by the endothelial cells. The most common questions usually we will be asked are, why is choroidal earlier than the retinal phase, as we can see the choroidal angiography patterns? And what are these choroidal watershed zones? And what is choroidal flush? So in order to understand this, even though the posterior ciliary artery and the central retinal artery are a branch of ophthalmic artery, the posterior ciliary arteries usually branch a little proximal to the central retinal artery. Hence, we have a choroidal phase earlier than the retinal phase. Okay. Next, coming to the next question is, what are these choroidal watershed zones? These are nothing but vertically oriented zones that extend from the temporal part of the disc to the macula, and these watershed zones are really important in case of AION. Okay, these are they can be anywhere between the temporal margin of the disc to the macula. What is choroidal flush? Choroidal flush is nothing but the patchy lobular pattern which we see in the choroidal phase. Understanding this basic anatomy, we'll move on to the principle. Basically, fluorescein angiography works on the principle of luminescence. Luminescence is nothing but it is maintained only by continuous excitation. The excitation occurs at one wavelength and it emits a light of longer wavelength. Here, when we white light is usually passed from a flash unit that passes through the blue excitation filter, as you can see in this image. As we pass the white light, the excitation filter blocks all the rays, allowing only fluorescence in the retinal vessels. And the unbound, which is important, is our unbound dye that reflects back both yellow green as well as blue light. Here the barrier filter stops the blue light and allows only the yellow green light to fall on the recording device. So this range of this wavelength is very important. So the blue range of visible spectrum peaking at 465 to 490, and the emission spectrum is 520 to 530. These values are really important. Coming to the equipment, we require a fundus camera, an auxiliary equipment, match fluorescent filters, that is the blue filter and the excitation filter and the barrier filters, the digital processing unit, 23 gauge scalp needle. We can use the fluorescent solution, which is the main dye that is being injected. It can be taken in the form of 5 ml of 10%, 10 ml of 5%, or 3 ml of 25%. The advantage of 5 ml of 10, if we take 10 ml of 5%, most of it will take longer time for the dye to reach the retina. Hence, we usually prefer 5 ml of 10%. Why not 3 ml of 25% is there's something called venous dead space which takes up the dye. Hence, what we say is 5 ml of 10% is usually ideal. And it is an orange-red crystalline hydrocarbon. 80% is protein bound and 20% is the unbound, which is available for us for the fundus fluorescein angiography. The dye is eliminated by the liver and kidney, and we need emergency standard equipment standby. You should always inform the patient, take a concern from the patient, and then give proper instructions before starting the procedure and go ahead with the procedure. Adverse reactions which we see usually are discoloration of skin, urine discoloration noted for 1 to 2 days. Make sure you always tell the patient prior to the start of the procedure about these adverse reactions. They can be 5 to 10% can develop nausea, vomiting following injection. In order to avoid this, you can always give slow injection. Extravasation with subcutaneous granuloma can also occur. Urticarial reactions usually noticed in 1 in 100, and the most anaphylactic shock, angioedema, myocardial infarction, bronchospasm also can occur, which occurs at the rate of 1 in 1 lakh injection. So always make sure that there's an emergency equipment kit ready for you. Coming to the phases, there are basically 5 phases which you can see in these images. The first one is a pre-arterial phase, also called the choroidal phase, where there is choroidal flushing or the choroidal filling, which usually occurs 9 to 15 seconds. There is patchy lobular filling of the choroid, longer in patients with poor general circulation. This is followed by an arterial phase. As you can see here, this is followed by an arterial phase. Here arteries are filled, veins are not yet filled, usually occurs 10 to 12 seconds. Next phase is the AV phase, where we can see the arteries are completely filled, veins have something called lamellar flow. This is because of the faster plasma flow adjacent to the vessel wall, as you can see in this image as well. Then it is followed by the venous phase. The venous phase is again divided into early, mid and late venous phase. From the early venous phase, there's usually more of the arteries filled, veins few are filled, not yet completely filled. Mid is both arteries and veins are completely filled. Late venous phase is veins are more filled than the arteries. There's something called foveal avascular zone, which is a dark zone of about 0.5 mm that you notice in a fundus fluorescein angiography. This is because there are blood vessels that are absent in the FAZ, and also there is a blockage of background choroidal fluorescence because of xanthophyll, as well as lipofuscin and melanin that is present at the fovea. Coming to the abnormal fluorescein angiographic patterns. Either it can be autofluorescence, pseudofluorescence, which is caused by the poorly matched filters, hypo. We'll be seeing in each type of abnormal pattern in detail. Coming to autofluorescence. Autofluorescence is of 2 types. It is called blue autofluorescence called BAF or NIRF, near infrared autofluorescence. What is autofluorescence is that emission of fluorescent light from the ocular structure even in the absence of sodium fluorescence. So dye hasn't been injected, still there are certain fluorophores that are present in our retina that are giving out the autofluorescence. Lipofuscin, when lipofuscin is the pigment that is giving out the fluorescence, it's called BAF or short wavelength autofluorescence. When it is melanin, as you can see in the picture, if it is melanin, it is near infrared autofluorescence. As you see the 2 images, both are autofluorescent, but what is the difference? As we can see at the fovea, this is the melanin that is giving out the fluorescence. So this is NIRF or near infrared autofluorescence, and this is BAF. Okay. Coming to hyperautofluorescence. Hyperautofluorescence is because of increased accumulation of lipofuscin, as we see in case of pattern dystrophy or Stargardt's disease or rolled edge of an RPE tear. Hypo can be in scene of RP atrophy, tear, geographical atrophy. This is very important. Geographical atrophy having a hypoautofluorescence, retinal and subretinal hemorrhage and a scar. So there is a study called FAM, which is nothing but fluorescent autofluorescent patterns in ARMD patients. So they have studied 195 eyes in 129 patients, and they have grouped them into following types. So if there is an increased fundus autofluorescence in the junctional zone of atrophy, yes, then they grouped into two types. Either is it at the margin or margin as well as elsewhere. If it is at the margin with in the form of single or individual spots, as you can see in this image, it is called focal type. If it is continuous in the form of a ring, it is called banded type. And patchy is a patchy appearance in the form of lamellar homogeneous pattern. FF at the margin and elsewhere has been classified into diffuse type, which is of 5 again. It is fine granular, as you can see dot around the geographical atrophy, or branching type, trickling, reticular, and fine granular with punctate spots. So why do we have to know these patterns? Because in case of patients having geographical atrophy, if we see a focal type of pattern, then we know that the patient is a slow progressor. Okay, so he's slowly progressing in his disease. If it is banded, it is a rapid progressor. Even diffuse is a rapid progressor. Patchy, not much study has been done regarding the patchy type. So always remember, focal, banded, or diffuse, whichever pattern is there, we can help to prognosticate the patient. This is a case of choroiditis. We can see hyperautofluorescence and here hypoautofluorescence. If there is hyperautofluorescence, there is still activity in the disease. If there is active hyper indicating active choroiditis, whereas hypo indicates healed choroiditis. Bullseye maculopathy, which is in day out, we usually screen in case of HCQ toxicity. Always make sure that you do a AF and rule out if we can see a bullseye maculopathy. Next is Stargardt's disease. What we can actually see how they differ, the BAF and the NIRF. This is a clinical picture. We can see flex and the central area, and on blue autofluorescence we can see a central area with surrounding hyper. As we can see in NIRF, the extent of the disease is more clearly evident in case of a melanin autofluorescent. The as we are done with auto, we'll move on to hyperfluorescence. Hyperfluorescence, we have 4 different patterns. It is transmitted, leakage, pooling, or staining type. In case of transmitted, usually hyperfluorescence will be well defined, slightly increasing in intensity, and size remains the same. Whereas in leakage, we have fluffy borders increasing in intensity and size. Pooling will be well defined, increasing in intensity and size. Staining will be well defined, increasing in intensity, but size remains the same. So what are these and how do we assess the patients and diagnose? We'll see in the following slides. So this is a schematic diagram showing a transmitted or a window defect. As we can see here, the RP is atrophied in this particular area. So the choroidal fluorescence is easily transmitted. Hence it's called transmitted hyperautofluorescence or window defect. And this visibility of the choroid is inversely proportional to the RP, meaning if there is hyperpigmentation in the RP, then we won't be able to see the choroidal vessels. And 3 basic properties of a transmitted or a window defect is that it occurs earlier in the angiography coinciding with the choroidal phase. And there will be increasing in intensity, no increase in size and shape. So these are the examples. As we can see in the clinical picture, we can see few drusens here in the temporal aspect, and these have increased in intensity, size remaining the same. By the end of the phase, we can see they have lost the fluorescence. This is a case of a drusen having hyperfluorescence window defect. This is a case of choroidal choroidal folds in case of a hypotonic eye. We are in which phase? This is a fundus fluorescein angiography of the right eye. In the AV phase, where we can see hypo and hyperfluorescent lines. Coming to leakage. So any fluorescence that remains in the fundus after retinal choroidal vessels have emptied, having a fluffy border increasing in intensity and size. So when we have a leakage, either it could be because already the existing endothelial tight junction, which was already there, has been lost due to the particular disease, like in case of diabetic retinopathy, microaneurysms, retinal vascular occlusions, or cystoid macular edema. or new blood vessels have developed which do not have the endothelial tight junctions, as we see case of neovascularization or tumors. So this is a schematic diagram showing in case of a cystoid macular edema. So the edema has developed clinically, we cannot make out so evidently. When we do a fundus fluorescein angiography, we can see something called stellate pattern. And if the cystoid macular edema is away from the fovea, somewhere around here, then we will have a pattern called honeycomb pattern. Why do we have different patterns? Is because the OPL arrangement is obliquely paced. That's why we have a different patterns for the same disease. This is a case of choroidal hemangioma. Choroidal hemangioma. This is a fundus fluorescein angiography in the AV phase, as we can see the lamellar flow, and we can see the hyperfluorescent choroidal hemangiomic vessel depicting the new vessels, and there is increased fluorescent the leakage by the end of the fluorescence. Coming to the pooling, next type is pooling. As we can see here, a pooling is usually seen in a sensory neural detachment or a PED. In this schematic diagram, we can see that this neurosensory retina has been detached from the RPE. This is a typical case of CSR, where we can see ink blot pattern. There is increased in the fluorescence by the end of the fluorescence. This nothing but pooling. When the other type is PED. In PED, as you can see, there is the fluorescence being completely filling till the extent of the pathology. It's also called as you can see in a rheostat. Rheostat in a bulb also has a similar pattern that is seen in case of a PED. That's how we describe SND and a PED. Coming to staining. Staining is another type of hyperfluorescence where there will be increasing in intensity, but there is no increasing in size, as we can see in this picture in case of a drusen. Hypofluorescence is of again two types. Either it is because of a blocked fluorescence or is a vascular filling defect. When we know it is because of a blocked fluorescence, we have to rule out either it is pre-retinal, blocking both the retinal of the choroid, or it is subretinal, only blocking the choroidal. Then the vascular filling defect, find out which branch or which has to be blocked and leading to a hypofluorescence. Sorry. So this is a case schematic diagram showing us hemorrhage in the RNFL pre-retinal. Because of this, the fluorescence has been blocked, hence we got a blocked fluorescence. Here both retinal as well as choroidal fluorescence has been blocked. On clinical examination, we found a hemorrhage in front, so it is definitely a pre-retinal hemorrhage blocking both the retinal and the choroidal vessels. So when you are given a hypofluorescent picture or any picture in the sense fundus fluorescein angiography, always make sure that clinical picture is there along with you, correlating with your findings. This is also a case of a blocked fluorescence where we can see retinal vessels are still seen. However, the choroidal vasculature has been blocked. In the schematic diagram, as you can see, here the retinal vessels are being transmitted, whereas the choroidal has been blocked. This is because of hypertrophy of the RP or CHEP. This is a case of vasculitis with blocked fluorescence due to filling defect. This is our own case of 55-year-old female who presented to us with blurring of vision in her right eye since 1 month. On examination, we saw hemorrhages occupying the superficial hemorrhages occupying her inferotemporal quadrant. Fundus fluorescein angiography was done, which showed a blocked fluorescence. This is also a case of BR vivo where we can see neovascularization, capillary non-perfusion areas. So what is the important, in both these cases, as we did fundus fluorescein angiography, what is the importance of fluorescein angiography in case of a BR vivo? It helps us to know the macular ischemic status, and it helps us to know the amount of neovascularization and then CNP areas that are seen there in the patient. Coming to CNVM. In CNVM, fluorescein angiography plays an important role. It helps us to diagnose whether it is a classic type or an occult type. If classic, is it predominantly classic or minimally classic, and where is the location? Is it subfoveal, juxtafoveal, and extrafoveal? Coming to the first picture, this is a classic CNVM where we can see typically called the lacy pattern and well-defined borders, as we can see here. This hypo is because of the hemorrhage that can be seen clinically, blocked fluorescence. So this increasing in intensity as we go for the end of the fluorescein angiography. This is the other type called stipple pattern with irregular margins seen in case of a fibrovascular CNPD in a CNVM. This is a case of a 56-year-old male patient who presented to us with history of type 2 diabetes since 12 years. On examination, we could see few hard exudates, microaneurysms, dot blot hemorrhages, and a small neovascular fond in the supratemporal quadrant. As we did a fundus fluorescein angiography, we saw the full extent of a neovascularization fond on the supratemporal quadrant and a large number of CNP areas and multiple neovascular leaks in this patient. This is a case of a 14-year-old female who complained to us saying that when she was having her Zoom class, she was unable to see the screen since 3 days. On examination, we could see multiple SNDs with hyperemic disc. On fundus fluorescein angiography, we could see multiple pinpoint leaks with SNDs in the late staining of late pooling phase in both right eye as well as left eye. This was a typical case of leakage. Patient was treated. So when you are given a fundus fluorescein angiographic picture, always make sure that the name, age, and gender is already there. So make sure that you know the clinical findings, see the first clinical examination. Then always make sure you take a autofluorescent red-free color picture and autofluorescent picture. Always when you are naming it, which eye, is there any arm retinal delay? Always make sure that you have all the sequences and you present it in the sequential manner. And make sure whether it is which level. Is it at the choroidal level, or is it at the subretinal level, or the neurosensory level? And then you comment on hyper or hypofluorescent. So my questions to the panelists are, this is the most common question usually will be asked. In case of CSR, we see two patterns. One is the in-blot pattern, which is most common, and second one is the smokestack pattern, which is going against gravity. So most common question to the postgraduates will be, why is the dye going against gravity? My next question is, other than AAON, is there any other clinical significance of watershed zones in the FFA? And a few contraindications, like patient has open wound or patient's creatinine level is 4, do we still go ahead with fundus fluorescein angiography? Thank you.
Congratulations, Pooja. That was great. You covered virtually everything, and great slides as well, and some images from Ryan. Very good. And some things I have to point out is that you showed different patterns of fluorescence and related diseases. And sometimes I have to emphasize for the residents and fellows that, for example, in diabetic retinopathy, and if we are looking at retinal edema, macular edema, we should wait up to at least 5 minutes. Otherwise, we won't see how much the edema is spreading. And this picture is good to see the extension of the macular edema, but also the beginning of the exam, the early phases, they show where it starts as well and the boundaries of the lesions. This is very important. And one thing that you pointed out is that many technicians, they perform the FFA, and we just take a look. But sometimes if you don't tell them exactly the way you want them, the exam to be performed, they might not do it very well. For example, you explained about the arm retinal delay. Some diseases, they have to take in consideration also if the patient has a carotid artery disease, for example, whether the dye is getting into the retina faster from one side, one eye, as opposed to the other eye. And sometimes the technician, he doesn't pay attention to that. He just take pictures. And so you gotta tell him, you gotta do pictures more at the beginning. You gotta do these pictures this time and this time. You have to tell him what to do. Otherwise, you are gonna be able only to get some from the beginning and some from the end, and you might not be able to know what you are looking at. So it's very important that
your FFA technician performs a good examination. Usually I have them perform the exam to me, but in some services, like one of my services that I work at in Brasilia, I do the FA myself. So the nurse gets the vein there to get things ready, and sometimes he cannot hit the vein and get the vein. I get the vein for him, and so we inject the fluorescent dye, and then I myself I keep doing the shots, and things go well because I know what I'm doing. I'm interested in the disease, and I know exactly where to look at. So it's very important, as you commented. And last but not least, on CSR, it's interesting that we always know that this fluorescent pattern is from the convection forces, and so the dye keeps moving, and it shows the interesting patterns from the CSR. The most important that we say it's pathognomonic is that the round one from the top that we call the chimney pattern, and but 80% or more we see it's the common one with what we call here the like the ink pattern.
Ink blot.
Yeah, that's it. Yeah, that's what we see most. And so I think you covered everything. It's important to look at the retinal periphery as well, because sometimes you have disease, especially vascular diseases, as you've shown well for branch retinal vein occlusions, and you have this hypoperfusion. And if you just display the image on the center, you might not get the nasal or the temporal or mid-periphery hypoperfusion there. And so this patient might need either injections or lasers, or, in the past we used to do only observation for CRVOs, but then we saw in the FFA that some of them needed laser, but not only for edema, because for laser for edema did not work very well, and then we came with the decision that injections would work better. But still, we have to look at the periphery of these cases to see whether ischemia is going on. So, very interesting lecture, very, very good actually, and you gave interesting examples. Jaydeep, did you like the lecture? This was perfect for me, perfect for
Yes, absolutely. It was a very, very informative lecture, and I think we should keep having a bit of refresher courses like this of basic topics. So very well presented, Dr. POOJA, and I think you covered, as Dr. Hudson said, most of the things quite well from the basics, and of course you covered all the common macular conditions, retinal conditions. But yes, there are a lot of other conditions which we need the FFA for, and as Dr. Hudson said, wide field FFA is very important nowadays, and checking the periphery for peripheral lesions is quite important, especially for some things like tumors on the periphery. So as we said, what you need to do is not only write exactly what you would like the technician to do if you're not doing the angiogram yourself, because there are certain things which can be easily missed if you don't give instructions to the technician, and they might not know where to focus and which eye to do first, for example, or what early pictures, which frames to be taken, and all those things are quite important when you ask for an FFA. So That is one thing. Plus, you should know how the machine works, and ideally, everyone as a retina specialist should definitely know how to do a fluorescein angiogram, ICG, fluorescein, all these things. You should know how to do yourself, because sometimes you may not have a technician and you might have to do it yourself. So you should be well versed with the machine and how to do the fluorescein angiogram, and of course the precautions, as you mentioned, what you need to keep in mind, because certain patients may suddenly develop breathlessness, or might even develop an anaphylactic reaction. So you should know how to react, what things are necessary to be kept there. You should ideally have a physician or a anesthetist standby, that in case of emergency, they can attend to the patient. So FFA is an invasive procedure. We should all know that, and so when we ask for it, we should have definite indication for it, and then only ask for FFA. Nowadays, we do have OCT angio, so there is an option available where we can, get away without doing a fluorescein angiogram. So ask for it when you actually need it, rather than advising it indiscriminately, because it is an invasive procedure. Then, as you described all the patterns of, and you covered autofluorescence as well as all patterns of hypo and hyperfluorescence. So what a newcomer should learn or know is how to identify these and not confuse between types of hyper and hypofluorescence, and what is the clinical implication of these. So I guess you've already covered it, and probably when we discuss a clinical case, I think we can go into the nuances of the angiograms as such. So it was a good overview of everything. Maybe we can have some case presentations based on FFA in subsequent classes, so that we can go into the fine details about things.
Yes, you are right. And you were telling about the OCTA. OCTA is very important, but I'll give an example. If we have the CSR, a mild CSR with the leakage, the pointy leakage at the very beginning, if it's not at the foveal area, it's extra foveal, for example, it's possible not only to observe, but it's possible to do a focal laser over there. So FFA will help a lot, as you see the focal leaking point there at the special area, which is not central foveal. That's just an example, but of course, if you have FFA, you're gonna get to be used to that, and autofluorescence helps a lot, as POOJA showed some examples, and I always
autofluorescence is very important,
yeah,
in mainly genetic conditions, genetic disorders, and ARMD, to follow up patients with geographic atrophy, and even in tumors, it is very important.
And also I like doing autofluorescence for surgeries, especially for macular hole surgeries. You see
macular holes.
Yeah, you
right.
see before, you see later. You have the I would say RPE behavior, and so you know what you are looking at. You gotta see these atrophic lesions, the hyper and the hypo. This helps a lot. So I think fluorescent angiography is not and won't be something from the past. It's something from the present, and I always like to have it all the time. What about you, Nageshwar? Good morning. You are in the OR?
Sir, can you please unmute yourself? Nageshwar.
Yes.
You are mute.
I was in OPD. Hi, Hudson.
Hudson. Dr. Hudson.
Hello, Dr. Nageshwar.
O senhor está mudo.
Hi.
Oh, Nagesh, good afternoon.
Sir, good afternoon, sir. Good afternoon, sir.
Yes,
How are you, sir?
yes. Very good, very good.
Nice presentation by Pooja.
Yes.
Thank you, sir.
So, she told actually, but one thing I would say, see this window defect is actually transmitted hyperfluorescence. Otherwise, it is called as transmitted hyperfluorescence. Usually, it happens because of any defect in the RP.
Yes,
So,
sir.
RP atrophy, which actually the accentuation of the choroidal fluorescence. That is what you mean to say. But you said Drusen's actually give this one transmitted hyperfluorescence. How I could not actually get, but usually because of the RP atrophy, where the RP will be less number or the RP is atrophic, then only you can see, or the stars particularly geographic atrophy, wherever it is. So you will see transmitted hyperfluorescence. That is what I see. So no. Hello.
Mm-hmm.
POOJA?
Drusens usually take up staining, sir. It's a late phenomenon which,
That is what actually Drusens usually they
yes,
get
sir.
stained. But
Some
you told that this is
yes, sir.
actually
Some Drusens, they said they can be, show a window defect.
so if it is associated with maybe some atrophic,
Yes, sir.
adjacent
Maybe in the
atrophy.
late phases, yeah, when there is RP atrophy, I guess.
Yes, there you can see.
Otherwise,
Another
staining, yeah.
yes. Another important is actually recently it has come, even the paper is come, wide angle FFA, fluorescein angiography. It is implemented in diabetic retinopathy to see, even in NPDR stat, supposed to see the amount of non-perfusion areas in the periphery. Very, very important. Actually, if you do laser in that cases, it reduces the number of injections the patient need. That is also very important. We will be just injecting the intravitreal injections to the macular edema, but when you will take care of this, all these avascular areas, CNP areas in the periphery by doing laser, sometimes it reduces the injections even. So
Yeah,
you will take your
it's important to see all the phases of the angiogram, all the phases. And especially as I mentioned in vascular diseases, we know why. We know we are looking at looking for the edema areas and the ischemia. And for drusen, as you said, you got to see whether they change in shape or not. If they do not change, they might be atrophic or just staining, or just atrophic, showing some window defects. But the thing is, it's very interesting. We have it to see the patterns of occult choroidal neovascular membranes. I think this is very important. Even though we might need other exams to perform, such as ICG, OCTA, but the FA pattern shows that something is covering something as the blood in the hemorrhagic choroidal neovascular membranes. So it's important that we do not forget to use FA as part of the whole examination. The thing is that some patients are allergic, and if they do not have not developed any allergies so far, so I would go on with the FFA, no problem. But if they developed these in the past, as J. Deep pointed out, I would do I would prefer better off doing the OCTA. But usually I can perform the FFA for virtually all patients. Very good comments, Nagaswar and
thank you.
Jadip. And who else is wanna comment? Do you wanna comment anything, Rodrigo? Rodrigo Morato.
No, doctor. Thank you.
And Carlos, are you in?
Sir, can you
Pooja,
tell?
Pooja
Yes,
has asked actually. Pooja
yes,
asked
sir. Yes, sir. I have asked the question, sir. In case
questions
of
actually. Yes.
in case of CSR, why do we have the mushroom pattern or the smokestack pattern against gravity? Is my first question. This
Because that
usually,
is
Yeah, so
related to, probably that is related to the molecular weight of this fluorescent dye,
okay,
related
sir.
to the
yeah, Now,
And
see, basically,
the current actually, the current of circulation, the fluid which takes the the dynamic moment of the fluid, one, and second is the molecular weight related to the dye molecular weight. That may be the
so
answer.
there is a difference between the molecular weight of the transudate which is there, the subretinal fluid which is there, that and the dye. There is a difference in the molecular weight. So the transudate which is there is having high protein content and have more heavier molecular weight. So then the dye floats up due to the convection current formed by the difference in the molecular weight. But
Yes.
there is also a pattern called inverted smokestack. So in that actually there is an inverted mushroom shape where the dye actually goes down. So that is in case when the protein content of this fluid transudate, that is SRF, is less compared to that of the fluorescein dye. So then there is an inverted smokestack pattern which is quite rare, but that is also documented.
Is it the same as inverted? Gravitational tract is same as that, or gravitational tract is different?
It is not due to gravity. It is not due to gravity.
Gravitational tract seen in case of CSR, is this the same?
That is different. No, that is different.
That is different.
That is due to chronic. That is in chronic CSR, where long-standing subretinal fluid will track down and form RP tracts. It will go and form inferior exudative retinal detachment, and once it dries off, in that area you will have RP atrophy along that tract. So those are called RP tracts. That is different, and this pattern is different. Inverted smokestack.
And the other question is asked.
Please go ahead.
The watershed zones in watershed zones in FFA. What is its significance?
Watershed zone, I think, is related to the blood supply of the, as you described earlier, the dual blood supply of the choroid and the retina, and it passes somewhere along the like temporal to the optic nerve, I believe.
Yes,
so there is a
probably that is related to this one, what arrangement of these lobules,
Yes,
choriocapillaries and the major choroidal vessels. So choriocapillary lobules arrangement of that may be the reason. And what do you say?
It's actually the junction between the medial posterior ciliary, the first branch is medial posterior ciliary artery and lateral posterior ciliary artery, sir. So the gap between these two is considered as the watershed zone, which is somewhere, it can be anywhere between the temporal margin of the disc till the foveal area. So correct. It is increased in AION. It is increased
in occlusions, AION.
Any other, do we actually, is there any other condition that we have to stress on these watershed zones?
Maybe in the ciliary arterial circulation defect.
Posterior ciliary artery occlusion also.
Okay, sir.
I think the case you showed, Negus, for a week ago, you showed the case with the spared ciliary artery.
Yes.
You remember that case? Interesting. And I found a case similar to that in the papers with a bilateral, I mean the combined occlusion of artery and vein, but with the spared ciliary artery. That was interesting. Okay, so thank you very much, POOJA, for your great presentation. We all learned. Of course, we do not have that much time to cover all the subjects because it's so much, and we are always learning with you and with everybody's experiences. And but before we close, how many of you would do allergic medications before the actual examination? You know, the PO medications for considerations into patients' allergies. Would you do that beforehand, or just go on and you make a small history and go on with the exam?
We are doing a test dose before. So on the skin test we are doing with the small amount of fluorescein is injected intradermally, and we check for any reaction. So after that test dose, then if patient is all right, then we proceed with the FFA. Of course, we do some basic blood investigations also, and if the patient is having significant systemic conditions, then we ask them to get a fitness from their physician, especially in renal conditions.
Also, I always take into consideration if the patient is allergic to shellfish or related shell fish and others, and I usually do not perform the FA, even though I see the patient for the first time, and then I have the tendency not to go on with the performance. And it's good to make a good and thorough history and
Yes.
see whether the patient has had this in the past. And I usually inject the slowest possible, not too fast. Of course, we have to look at the time from the arm to the retina, the 10 seconds things, but I prefer to inject a little slower. So otherwise, I see that people that inject too fast, they come with nausea and other symptoms. So I prefer to inject slower. And then another thing it's very important is that you have to take good attention to your equipment. Because for color peaks, you use the filter, and for FA, you use another filter. If you keep photographing with the filter from the FA in the color peaks, you might damage it as well. And so sometimes you are not going to be able in the long run to see well your angiography, because the filter is kind of blowed. So you got to be very careful on that as well. Use the appropriate filters. And also for the patient's protection, if you use the very F1 filter, for example, and you do a very high flash, very strong, and so the patient might get some damage during the examination as well. It's not good for him. He won't be comfortable. So I prefer to start with lowest ISOs possible, and if it's necessary, I put the ISO a little lower, but the flash from the equipment, it's usually around 320 or 400, not more than that. Otherwise, the image might get, very, very, very white and blown. So another things to have into consideration is that you do the correct timing between the pictures. So at the beginning of the exams, the phases, I start to doing and doing like the burst photo. You see, you one after the other. Otherwise, you may miss the correct phases from the angiography. And if you have a lesion in the periphery or not at the macula, then you need the patient to have the eye turned sideways so that you get whatever you are looking for. And I also tell the technician, in case you don't do that, you don't perform the exam, that he has to photograph that specific area. So we make a drawing from the lesion before referring to him. Otherwise, you're just going to photograph the center and won't do anything that's probably necessary for the disease.
Right.
Yes. Yes, Absam. I think excellent.
It's because Natarajan sir should say something. He has to give the key points on FFA.
I think all well covered, and And this point also, I didn't say, but I think we make it a point. We have the anesthetist available whenever the angiography is done. And if there's a history of allergy, then we do allergy test. Nowadays, I think if the patient has an allergy, then we directly go ahead with the OCT angio, so that we don't do the fluorescence angiography. And then we have had, I think long time back, a patient with allergy and then treat them with the steroid. So we make sure everything is available in the FFA room for the patient to lie down and if required to intubate. Fortunately, if you take precautions, I think it's fine.
Yes, and I also will have to think of the dye, the concentration. I prefer to use the 20% concentration, which is higher, so I see better the image. But in some cases, you don't need to use 20%. You use 10% for very mild diabetic patients, for example, that you want to see just the pulling, you know, the microaneurysms and things, and you don't have a flourished pattern of characteristics. So I tend to use a lower concentration of the dye, but usually I prefer to use the 20% as well.
Usually every 20.
Thank
you very much.
Very good. So, what is the next? I think next is on OCT angio. Aishwarya?
Yes, sir, we can have OCT angio. Dr. Hudson was asking whether we should have one of his PGs next week. If not, then I can present, sir.
No, Hudson, whatever you said.
Yeah, but I think she's already prepared the OCT A, and I think it's going to be cool to have your talk this time, Aishwarya, because OCT
yes, sir, sure.
already prepared, and we could make the complement as well. And I know that you prepared a very great lecture, but for the sake of time, last time we talked about OCT, it was not possible to put all together. And I'm going to arrange some examples so that we could discuss on as well.
Yes. And also, yes, wherever Aishwarya can take presentation where we have done fluorescence, ICG, and OCTA, if we have, then show some comparison.
In between, can you discuss a few cases, sir?
Yes.
Can we discuss some interesting cases, clinical cases?
Yes. Definitely.
Yeah. It's interesting because the case that you put, for example, in the WhatsApp,
yes,
it was interesting. You know, we learn from these experiences as well. So we see theory, and so we then have the examples for the practical terms. And as I say always, we can never forget FFA and add with the other complementary exams, and we have a very good diagnosis, and that's what we need.
Right.
Thank you very much. We are very happy, and thank you, Natarajan. And
yes,
say hello to your mom.
Thank you, sir.
Thank you.
Thank you, Jaydeep.
Wonderful.
Thank you, everyone.
Thank you so much. Thank you, everyone, sir. Thank you.
See you, Nicole, Carlos, Rodrigo, and see you next week. Nagaswar. See you.
Yes, sir.
Thank you, sir. See you next week.
See you next week.
Bye-bye.
Yes.
Bye.
Bye.